record your name. Has difference. Has joined the conference.
Tomorrow, body. Yeah.
Quickfield.
Has joined the conference. Has the conference.
Minutes before we get going.
Nina.
Conference. The conference. Has joined the conference. Has joined the conference. Has joined the conference.
Laura Freeman.
Has joined the conference.
Haf Ali.
Has joined conference. Has joined the conference.
Get going now.
Has joined the conference.
To all the people who are going to join while we do the setup, but we might as well get started. Can I ask everyone, apart from Stephen, to mute their phones, because otherwise there's a lot of background noise on the call. Thanks, Bill.
On the telephone, yeah.
Excellent. As long as we can do it, then that's the key to everything. This is the first, as a way of background, this is the first of 4 Wales and associated reports that will be producing on the OR&E team, then requested by the Vanguards as part of the support package. So these evolve around air Vanguard sites have requested further information and evidence around implementation of specific topics, and this one is around care closer to home. We have commissioned the South East CSU to undertake this work, and this particular piece has been led by Stephen Peckham from the University of Kent, so we're really lucky to have him involved in this because his experience around care close to home, so he'll actually be expanding further than just the review, but also giving some further roundabout work he's done in this area before. With regards to questions, we're going to have time for questions towards the end, so you can do that. I'd like doing it via the chat option rather than everyone trying to jump in via the otherwise it could get quite messy. So if everyone can try and use the chat option to line up questions when we get to that, that would be good. So I'll ask Stephen in a second. I guess I should introduce myself. I should have done that right at the beginning. I'm Jerry Chard, and I was the evaluation lead in the Operational Research and Evaluation team. So we're Mike Laurie and Laura Freeman and others with models evaluation. So if everyone's happy with that, I will hand over to Steve will take us through the slide set. Can everyone check everyone can see the screen? Some or I'm taking that as a yes. So over to you, Stephen. I'm going to mute now.
Thanks very much, Jury. Good afternoon, everyone. Yes, I work here at the Centre for Health Services Studies at the University of Kent, and I also hold a post at the London School of Hygiene and Tropical Medicine. And all my sins, director of one of the Department of Health Policy Research Units, looking at commissioning in the healthcare system and looking over the past 6 years that developed clinical commissioning groups and issues such as contracting, competition. We've looked at the public health system, and a number of pieces of work around care, including looking at a whole balance and issues related to community health services, and we're continuing to do some work on that, which I might come back to later. I'm actually not on my own here. I should introduce Sabrina, who works here at the centre, who's done much of the background work, and so I'm thankful to her, and with the questions I may need to ask her to help me to think about some of the evidence. I'll try and go through reasonably quickly because I think it might be more useful if you are able to ask questions, and I can't promise we can answer all those questions. Hopefully the presentation will answer the questions. If there are specific questions we don't know the answers now, what we'll try to do if the evidence is there, incorporate that into a written review, which will be sent out in about a month or so's time. As I'm going to crack on and just kind of a brief introduction to everything.
Joined the conference.
The background to Care Closer to Home, talk how we've gone about looking for the evidence, and then through some of the key areas around Care Closer to Home, which we thought are of particular interest, identify some of the issues around economic and social costs, which are quite important, and much gaps, but obviously leave time for questions at the end. All of you are really aware that the Closer to Home is really about thinking how we can deliver care outside of acute hospitals and in the community. No idea. I can remember looking at this many years ago, even during the 80s and 90s, the whole issue about how you shift care from hospitals into the community. Essentially, though, is to try and cut the number of unplanned admissions and try and reduce the overall social and economic burden on both users and providers, and that's something we will be coming back to later. But how about this is that we looked mainly at the most recent literature. Felt this is really important because of the obviously shifting context of healthcare in the NHS. Actually, thinking about post-2006 white paper, which looked at particularly pushing forward on community health services. And, at the why and what necessary, thinking just about whether something is done effectively. And I'm going back to the whole issue about the how as well. And we crawled a number of databases to see what we could find. So, some of the that it is thought that the current system of delivering healthcare has become unsustainable. I mean, I'm not sure that's not necessary now, but clearly we are again in a very tight financial situation in the NHS, and part of the whole reason DERT's developing new models of care to look at ways of doing things. Things that traditionally have done either in the acute care setting or, in fact, many things that we now want to do for people who live in the community can be effectively supported in the community. There's no doubt that there are many things I think now in terms of delivery and support for people which are in hospital, which are now done quite well in the community. Well, including changes in the population, both in terms of aging, but also the increase in complex and chronic conditions is in the acute care setting. It's causing problems certainly in A&E by increasing the amount of time that people who turn up at A&E end in A&E, and also obviously stronger likelihood that from A&E they'll be transferred to a hospital bed. So this is something which does cause pressures on hospitals. And think about alternative options. Can we carry on?
Has joined the conference.
To add more beds into the service, which clearly is not something we want to do. I think a number of components. So care closer to home isn't one thing. Tend to talk about it, or many years ago we talked about community health services, but care in the community, there's a number of different things. There is no single concept of care closer to home. And lots of things that we're particularly looking at, and things that have been developed across different guards and not in vanguards, but across the NHS, both in this country, but health services abroad as well, and enhanced community support, developing virtual wards or hospitals at home, improving the use of telehealth, making use of better and new technologies to support people in their own home. The idea of step-down care, the idea that you would move people from hospital into kind of halfway house, also to avoid admissions, you might have this idea of a halfway house. And eventually, obviously, what we're trying to do is the admission avoidance and stratification, that actually we'll be coming back to later in this series of webinars. And I'll look at some of these one by one with some evidence and some examples. Enhanced community support around using virtual wards. This is here that you're bringing, in a sense, a team of health workers to support people who are living in their own home. You want to stress that people who are in their own home, you're involving social care professionals and the informers, but potentially also the patients themselves in providing self-care. Patients with fairly complex care needs, and it's important to think about how you develop collaborative and coordinated patient care, because of this it will be very fragmented. And we're about workforce in the next webinar, but the evidence that supports of integrated working and team working is actually very thin. So this build is the real complexity about what's the best way to do this. There have been demonstration sites. One in particular is the Tayside, which we made. This is a group of and an increased number of voluntary admissions. The is covered about 37,000 people, and these about just over 4,000 were 75 plus. It's working across health and social care with multidisciplinary teams and trying to develop a much more integrated approach. In terms of outcomes, it involved actually a very highly coordinated effort. But I mean, lesson one is coming here. It involved a great deal of investment and engagement during the pilot, because it was in a sense successful.
Has joined the conference.
That it was found that people could be moved outside the hospital. That care was effective. That it reduced out of hours and A&E costs, and was more effective than hospital admission, and particularly for the 75 cohort, the 12% decrease across practices. It is clearly something which is of benefit, but I would stress that it took a lot of coordination, investment, and engagement. I think when we did the evaluation of the care networks systems in London, what we found there is that there wasn't sufficient emphasis placed on the importance of investing. There was an expectation that you would get returns within 1 year, and after 2 years, they were still trying to set these sorts of processes up. So stress the point about the need for investment, but also engagement of professionals, of the local community, of all the different kinds of organisations that might be involved. Say that patients actually like it. In terms of the positive experience of patients, that was much better. And staff
has joined the conference
and wider range of services that were available in communities. Evidence shows that actually NHS staff in particular are not very good at knowing the kind of range
has left the conference
available locally. But again, there was an evaluation of a scheme for virtual wards involving Croydon, Devon and Wandsworth. This is about setting up teams of people to look after people in their own homes. Though, again, there's no one interpretation of what a virtual ward is. So the cost of interventions in Croydon was £3, in Devon it was £17 per patient. And the problem is that they were doing different things. So one of the key problems of evidence in this area is, again, that often people are doing very, very different things, even though they're calling them the same name. And many of you might have read the work around community matrons. And again, the idea of a community matron was interpreted very, very differently across the UK. The problems were also exacerbated by inconsistent results. There's a lack of coordination and communication, engagement between the care services, back again to that lesson of needing to work quite closely with other organisations. Little step down care. So this is about early discharge on the whole. It is also about prevention, but most of the research has been looking at discharge rather than people going into hospital. The idea of transitional patient support, and the idea is that you would be able to remove people from much more high cost. Now, some of these are invested with acute settings where wards are set aside as step down. And when I was working in Southampton, that was done in the 1990s. And some are actually in the community, maybe community hospitals, or it may be thinking about how you can support in some kind of interim process. So it might even be an enhanced nursing home or a nursing home or enhanced residential care. And there's been some audits looking at these types of interventions, and it's been a cycle of audits undertaken by York. So at a range of things in terms of trying to cut down hospital and care home assistance, look crisis response, home-based intermediate care enablement, for example. In 2014, there was the fourth cycle. There was an extra element to that. It was about looking at social well-being. Actually provides some quite useful information. It was a huge study. It looked at over 300 services, and I would stress again, that's 300 different types of services, 1,000 patients, and also working with practitioners and communities. So it's a very, very large study, and I think we can kind of take good stock of what the outcomes and evidence is. The point is that 2/3 of patients reported a positive impact on their well-being. This was when it was measured in 2014. However, like the other studies, the financial benefits are not clear. Overall service costs increased between the third and fourth audit. That rising care costs, but it's not clear about what the reason for that is, because of physical restraint. That costs are difficult to ascertain, both differences in care, but the problems in the community sector is that to identify specific costs, as I'm sure you well are aware, is very difficult and undermines any approach that you might want to do in terms of cost-benefit analysis. But and in particular, again, this whole idea of service engagement and investment in care, such as hospitals at home and step-down care, can be effective in terms of the early discharge of patients. Telehealth is a very, very big area, and often been looked upon as the answer to many of the problems of with people in the community. I'm going to talk about telehealth as if it's a separate thing that's done, but anyways, telehealth should considered to be part of the ordinary type of care that's being delivered, except elements of that care may be done electronically. Here is that through self-monitoring or remote monitoring, could limit unnecessary hospital admissions. The tech also includes professional communication, exchanging information, using data, an extremely broad area of work. I mean, it's fair to say the Nuffield Trust did a survey a few years ago, and whilst there is quite a keenness patients around how they use telehealth or digital care, the actual use across the UK is that only about 2% of patients are actually using it to any degree in terms of delivery of their care. So it might be possibilities, and certainly there's patient willingness to engage a little bit more in patient care. Where it tends to be used has been in things like set appointments, information between, thinking about a little bit of self-monitoring. But a lot of that, there's a problem around the interoperability. So the data might be collected, but it's difficult to share the data. Some of the key lessons from the telehealth work has been for look at your data and electronic systems, but all training for staff, communicate and share data, how to use data, how things like data-led decisions. Make sure that skill and technology are part of the competencies of your staff, and actually thinking about how you train staff around some of the issues of using telehealth. So familiar to them, because obviously, but it would, if you want patients to use it, your staff need to be able to do that with ease. There was a very system demonstrator. This was a huge randomized control trial of telehealth and telecare. 6,000 patients across 238 practices and running Cornwall, Kent and Newham. And did find there was a reduction in A&E visits, that days were reduced, emergency admissions were reduced, elective admissions were reduced, and mortality rates were reduced as well. But the problem is that this wasn't one thing. There are a variety of different telehealth and telecare. So it's not possible to say at the moment that by introducing, for example, self-management in terms of monitoring will definitely lead to these kinds of things. But clearly, it would suggest that some investment around telehealth might have a positive benefit. I'm afraid a lot of good news, but that is the good news. Some of the more difficult stuff is around the economic costs and costs. Overall picture on cost is not particularly well developed, but what we do have, basically, we have variances in the cost of hospital stays. Actually, we have variances in the costs in relation to the community. So these aren't static costs, so therefore doing comparisons is often quite difficult. But overall, broader view that my policy research unit did a couple of years ago for the NHS, which has never been published, did suggest that you could do a lot of these things, but the overall cost to the NHS doesn't have to be affected by many of these investments. And I think there's certainly need for a little bit more research around the costs and economic costs. But are actually looking as if they're going to deliver substantial savings around the NHS. But against that, there are positive benefits in terms of both patient satisfaction and patient outcomes. So basically, I'm afraid that the simple moving away of care from hospitals potentially yield little financial impact. And again, and this is one of the problems we faced with the policy system work in London, is that your fixed costs around hospitals are so great that it's very, very difficult to disinvest. So for economies trying to shift costs, it isn't difficult. And I know from the 1990s that you're talking about a 1% shift. So we're not doing major shifts around some of the costs. So I think we're looking at long term, we're looking at piloting, the importance of actually monitoring those pilot schemes to see how they develop and ensure that we have the money for investment. And that's where one of the key problems is clearly at the moment. And we should perhaps welcome Simon Stevens at least arguing for having term investment to allow us to change the system. But we do know that you can, with better coordination, improve patient pathway, improve patient care. But actually, a lot of that is much more difficult in the community. I remember moved a physiotherapy unit into the community, and it ended up in 5 different sites. The complications of trying to coordinate some of that work. And the other thing that we found in the London example is that the services are costed, but don't forget to think about the infrastructure costs moving things into the community. So these are just things like how are bookings made, who does that, what are the admin support arrangements, how they link together in terms of the IT and infrastructure, how they link to hospital databases. So some of that thinking gone on, what people were thinking about is how do we move X service from a hospital setting into a community setting, and we do that, and can we do it cheaper? But they think about, well, who's going to be on the reception desk, who's going to be doing all those kinds of things. All that structure is critical to make the successful transfer. From a patient perspective, as I've said, the patient experience is far more positive, and when patients are treated closer to home, is not completely universal. Clearly, some people still benefit from services are brought together in one place. That may be in the community, but it may be in hospital as well. And there is a suggestion that we can have a reduction in mortality rates and certain rates of readmission, as well as some suggestion that there are potential benefits in terms of avoidance of admissions, and particularly keeping people out of A&E, and also improvements in discharge. But unfortunately, huge evidence gap in this area, and I think that really makes a point about how important in doing what's happening at the moment in the UK, in England, is that it's properly evaluated and looked at and examined. And in particular, some really, really good data around some of the process and organisational issues. That's thinking about how care is moved in, what are the costs associated with moving services, how to think about coordinated care, what is it we need from patients and hospital, health and social care voluntary to be effective. We need to look at the financial cost benefits, and we also need to think much more carefully about delivering culturally appropriate care. In a severe criticism of hospitals, but it becomes even more critical if we're working in the community, and particularly working with formal carers who will be providing a bulk of the support to people who are outside of hospital. But back to my initial points here about income really and financial investment. You know, if we want to get improved outcomes, improve coordinated care, decrease in mortality, decrease admissions, or any potential financial benefit in the long term, it actually takes substantial investment. Things that we learned from the London system is that it's better to invest in one area at a time rather than try and do lots of things, and not to do it on such a small scale that you can tell whether it's effective or not. Many projects that were done in London involved maybe 100 or 150 patients, and clear whether that was particularly effective or not, both financially or in terms of the effectiveness in terms of outcomes as well. So there is here about scale that's important. So making sure that the data is being collected to enable you to assess whether particular intervention and interventions and so many other things affect the outcomes for patients. Trying to focus on particular areas is probably a better way of investing, trying to do lots and lots of things in one go. But to say, so I'm very happy to try and answer any questions that people have regarding what we've just gone through or things that we didn't cover. You would have liked to have known about, and we'll take a note of those and we'll try and answer them now, or we'll go away and look for the answers. Thank you.
That was really good. I know people on the call who weren't able to see the WebEx because their systems don't let them through the firewalls. I was just thinking of you who weren't able to see it, were able to have any questions at this point because you wouldn't be able to use the chat facility. If there's anyone on the line who wants to ask a question.
Sian Davis from Hampshire. I just wondered, when you said about these small scale and the small patient sizes, I mean, what would be a minimum patient number for some sort of intervention where you are re-stratifying and identifying the most vulnerable patients and then having an intervention?
Yeah, it is quite complicated because it might depend on what's wrong. So the examples I gave were about vascular support and a self-management program for diabetes. Those were two of the things. And I think what you're looking there at is not to trial it. So what people were doing was trialing it in one practice. It's a benefit of trying to go across practices because contextually practices are quite different. And in terms of numbers, you're virtually into getting advice when you start a program. It's actually taking advice from maybe your local research support unit on might be a viable in terms to demonstrate. And if you've got a research partner, that's much easier to do. A viable number of patients to be looking at, because what you want to be doing is spending a lot of money, but it will vary obviously from patient group to patient group. Now I know that's not, I can't, in other words, understand, I can't give you an answer, but the small numbers of where you try
Coulter has joined the conference.
Don't often pay out the benefits. So it's about thinking, well, we would like to do, let's say it's around with problems, you know, at what scale? Well, generally, actually, you'd be talking probably and trying to do it across a line. It depends on the size of the reasonable chunk, or trying across the whole MCP or Vanguard, if you can, again, depending on the Vanguard. But my suggestion is that if you're outcome patient benefit, you just seek advice at the beginning. What we find here is that people come along and tell us, oh, we're doing X. You tell us whether it's effective or not when halfway through the project. So that's partly a plea. And I'm sure many research units would be happy to give advice, even not necessarily then going to be involved in any of the evaluation, but I'm sure they would give advice.
Are there any other questions from people who otherwise I'll just open up the questioning to everyone via the chat. Yep, sorry. Go ahead.
It's James from South Hampshire, that's local care as well.
I'm interested in the outcomes from it. So I've got a copy of the presentation. I'm on the phone, so I'm not sure that I can see everything. I see that there's some dramatic impacts from the telehealth project. Mortality rates down by 45%, and that seems like a number to me. But how that was worked, and actually across the whole range of the different interventions that you looked at, because there's a number of completely different types of intervention, whether there were key themes that you thought were most important to follow through?
I mean, we can probably expand. It'd be easier to expand on, make sure we expand on this when we send out the review, because what we do is to break down some of the work on the whole demonstrator side. I say that the demonstrator side tends to work with older patients, and the mortality reductions would have been within the time frame of the study, which I think years, if I remember. If I put a different hat on, there was a real interesting problem, and I know that the people at York Economics read this, is that what any of these interventions with these reductions in hospital use and mortality in the period of this, and this is a recent problem, doesn't tell you is that people will eventually become ill or more expensive or have more at some point in the future. And it's not saying that they will, it's just one of the problems about a lot of what we do, which is why the plea for monitoring and audit is really, really important. I mean, saying things, or whether we are actually, in particular with prevention, which is an area I've done a lot of work in, whether we're just staving off the inevitable. Now, that much more economic perspective, from a patient perspective, of course, that's very, very positive. So mortality, would the expected mortality in the time period of the study, which may seem greater, but that, you know, if you're one of the, what would it be, about 3,000 patients, that of course is extremely positive. Is that?
That's really helpful. So, are there any particular themes across all of the different types of program that you looked at?
Yeah,
that
we'll
most
pull that information out you. I when it's all, it will more probably actually apply particular things, but we will definitely pull that out so that when the review comes out, it's very clear.
Thank you very much.
Okay, have any questions this time? I've opened up really, so just jump in.
Here from Tower Hamlets Vanguard. Stephen, that's really helpful. One of the comments you made is about investment, and really recognise that actually it does require a lot of investment up front. Would you be able to say a bit more about what you mean by that level of investment? Is it around care coordinators, or what specific would you think there?
Well, ultimately, the first one, that it costs money in the short term. Often what you're doing is done up. I mean, as you know from the policy system in London, that it was a bit, should we say, optimistic that you put that additional investment over a short period of 12 months and expect to see the reduction in costs. What we found is that those additional costs carried on well, it's over the full 2 years of the time period that we were looking at. The other problem we also found in London, in particular, is the fact that people are more mobile and where open access services develop a real problem with cross-checking, which is something to think of. So funding is certainly one thing. The other thing is investment of time in terms of planning and putting resources into supporting and developing projects. The things don't necessarily happen by the time. So again, this is perhaps another reason for focusing on areas rather than trying to do too much with limited management and professional resources. It's to focus on one area, he'll then move on to something else. Here in Kent, for example, we moved psychiatric nurses from acute settings into community settings, focusing on one particular type of transfer in both the patients and the staff, actually proved very beneficial and came up with both cost and savings and patient benefits. A lot of input into training, supporting, planning, organizing at the beginning of that to ensure that it worked properly. And it was in the end, like things more time. They in fact found that much more complex. So it's not necessarily about a specific such as a care coordinator, but it's sitting down and thinking, okay, if we want to do service, for example, into the community, it is a bit of time and resource in the planning stage through these things, as well as identifying probably tailing off investment if you think you're going to get some success out of it. It might be a care coordinator. It might actually just be the importance of having somebody identifiable has a responsibility for following through and coordinating the various elements. That's both resource in terms of, but also thinking about how the planning might develop as well.
Any other questions?
Tracy Gilman, Roche.
Yep, go ahead.
Almost following on from that one, because one of the conversations you talked about later on was that there probably the lack of costly infrastructure, and that the literature was suggesting doesn't deliver substantial savings to the NHS for a number of these projects. And I guess my question stroke concern would be, as a vanguard with limited resources on probably a time scale, is there a point for some of these projects that says, if we're not going to get a return on investment, can we continue to deliver them if there's no savings to be pulled out of the acute and then transferred over?
Yeah, I mean, the transfer of stuff from acute is particularly complex because with finances from an acute setting, I mean, it's back to a scale problem. You know, the acute thing is that you can't do it bit by bit. You know, we know that as a lesson. I can go right back to when I worked in the voluntary sector in the 1980s and set up respite-type care to stop people using hospitals. You know, develop a big enough respite system to be able to close a large proportion of the elderly care hospital, which we couldn't do at the time because we know how much it cost. They were still on the previous year's budget. So, but that problem of fixed costs in the hospital, we really have to work well with the hospital to move things, and that again involves forward planning and thinking about what's going to happen. The infra costs, then bits that are often in community, and I think that's a real, you know, move serve into the community. You know, in the hospital, many of the infrastructure costs are across the whole cost of the hospital, and they appear in the budget lines for specific services. We're also getting better at that in terms of cost center. But when you think into the community, your cost center is absolutely there. You know, particular room for maneuver around that. Starting to think about the structure cost. Now, in terms of pay on investment, there's two things to consider there. I mean, if improving patient care, then saving any money may be okay. But nationally, of course, we're looking at cost savings. Really, the only cost savings that we're going to be able to generate are substantial hospitals. So going back to London, we want to save £2 billion in London. You close one of the hospitals. That would save the £2. But to plan on that scale is I can't even imagine how you would do it, to be honest. So thinking a little bit about the bad, therefore, you might want to do things because it may not necessarily cost. Not be able to show that in the short term, but if you move to the community and support people in the community and to restrict people in hospital in the long term, you may get some out of that because the two things that we know, if we can get people moving into A&E, people, and be a significant cost save. So I think it's about picking off, as you would expect to think about, what are the kind of key cherries that we can perhaps look at a little bit more in the but to the fact that because where we are with the evidence doesn't say that if you do X, Y will definitely on. And most studies have not been specific enough to look at whether a particular element of a program produces benefit, but perhaps point us in a direction that suggests that we are doing more of this and kind of think about how we contain costs and reduce costs in hospital, then we actually end up with some financial benefit as well. But I have to say the jury is really out on that point.
I think that's one of the challenges for us all moving forward in a number of our projects. So, yeah.
That's why it's research these things and to do them.
Has left the conference.
Okay, do we have questions? I've got one. I just wanted to ask the career rounds you were talking about the multiples and trying to pull out being effective in terms of change you see. You know, what's the strategy about going about trying to do that? Because obviously Vanguard, they're not single engines, they're very much engines. So when we're going about evaluating them, how would you be looking for that in terms of attributing changes?
Part of it, Jerry, is really paying attention to the difference of what the vanguards are doing. So the first thing is not to treat EP as something which is an MCP. An MC, for example, would be a conglomerate of things. And I think, the thing you need to do is to start to break down kind of organizational and process elements, organization, and the services that it provides, and some of the interconnectedness of that. Now, the foundation frameworks, and certainly ones that we're working here with our local Vanguard, and have also inputted, in fact, Jenny Bill has inputted into some of the national work, has actually started to think about how we do that kind of more complex approaches to evaluation, which most evaluations, because a lot of the evaluations get hard data on science and patient outcomes, and But actually, we also need a lot of the evidence around processes and organisations and how they impact on the way things are done. That is how bit, which is important. So I think, you know, the things are is not to kind of think about these as single entities. I mean, this is a lot of the work we've done in clinical commissioning groups. We've done it exactly the same way. Although we talk clinical commissioning groups as single entities, they're not single entities. They are networked, for example, of practices. They are different bits. And so what we try and do is break those down as we look at them for specific aspects of it. I think Vanguards, one of the things you can do is look at some of the specific services and see how they're developed. And it may be because if we know that planning, investment in the kind of infrastructure resources that are needed to actually change services to get perhaps more integrated services or different ways of delivering care. I mean, things that Vanguards might be better at is bringing the kind of engagement of the different organisations together. So the Vanguards themselves may be fulfilling some of the preconditions. So what I understand is what the Vanguard is doing that enables them, which wouldn't have enabled a different type of organisation to do that. So that'd be another way of starting to think about these things.
Thank you. I think I'm struggling with it at the moment, but
I was struggling.
Okay then, that's been really good. As said, you can feed back to me or him any questions you have and any comments you have about what you'd like to see in the review. The itself, which will be a document, will be coming out within the next sort of 2 to 3 weeks. So I'd like to thank Stephen for his time and for a very interesting presentation. And both the next one will be in which will be on workforce, and we'll send around details of that nearer the time. Thank you for your time, everyone.
Conference has left the conference.